You know, I've done this a few times, and I really want to talk to you guys. I don't want to talk at you, and I don't want these slides ever to come between us. You know, you say, "Oh man, that looks too complicated," ooh, you know. And so, what the slides are really all about are cues. Cues for me to say, "Okay, now I want to talk about this." I can't cover everything on the slide. I don't mean to, so I'm going to just highlight some things that you find interesting. Questions, we'll address those later. But basically, whenever we do any kind of engagement in advancing the care, research and stuff, we have certain disclosures and interests that we've accumulated, and my interests are shown here. I usually partner with industry colleagues that I agree with their what they're doing at the moment. We don't, you know, you don't jump on every opportunity, but you jump on the ones that you can. I've working with a group down at Medical College of Georgia at Augusta University. And then industry. This is where Dr. Shahan was saying if industry's in the background, they can't be in the foreground. And so someone has to be that intermediary to coordinate things with them. So looks like we got this maybe cut off a little bit, but the key word here, if there's, you know, each slide is going to have one key word. So the key word here is heterogeneous. So what do we need by that? Well, you know, this is a conglomerate of symptoms, of diseases, of primaries. These cells are really ubiquitous throughout the body. So the minute you say, have you ever seen somebody with X? Well, yeah, I have. You know, like, you'd be surprised. Some of these tumors can form in you know, skin, pituitary gland, in the genital organs, in the kidney, in the even liver primaries. That's rare, but clearly gut, lung, pancreas are really our focus. And so this is sort of how the body's put together embryologically. It tells us a lot about how the tumor may behave. So those tumors that arise from the foregut are going to be those coming from the lungs, thymus, stomach, and the very first portion of the small bowel. And then we think of the middle portion. This is more the mesodermal part of development, the midgut, small intestine, appendix, proximal colon, and then the gut. So these tumors form from a different layer embryologically. So their biology is different. How they present is different. When we just look at these, we say, you know, right here's your serotonin thing right there, small bowel. Now, can the other tumors do it? Yes, they can, but very rare. You know, we'll say less commonly. Some very rare. One of the questions that we come out with sometimes is, can you have a pancreas primary, this one here, make serotonin? Well, you maybe 1% of the time is about what the numbers are. Well, yeah, it can. It's been reported. It's not something that we commonly see. As a result, we don't really get excited about serotonin when we have a pancreatic primary. Why not? Well, because it's a low likelihood of doing it. And at the same time, when we look at the small bowel, do we get excited about these tumors making insulin? No, we don't do that. We don't get excited. Oh, yeah, your insulin could, if your insulin or your blood sugar and all that's elevated, it's probably because of other reasons. So the key thing from our perspective is to kind of know your enemy, know where the primary is, know where the disease is. So if we know where the primary originates, it gives us we're that much more ahead of predicting what the biology might be. Sometimes it's difficult to do that. Sometimes the primary is occult. Sometimes we never find the primary. We do have molecular testing that the genes, the fingerprint of the tumor tells us where it comes from. So we have a test that we can run on the tissue, on the biopsy, look at that fingerprint, and for neuroendocrine tumors, about 95% of the time gets it right. So we can know the primary even if we don't see it on a scan. And so many times I've seen somebody and say, well, we don't know where the primary is. Well, I do. And if you see this disease a lot, you can figure it out. It's no secret where primaries are in the majority of cases. So it's something that you're going to hear probably multiple times today, we're dealing with a rare illness, but the incidence is increasing. It's not increasing in a way that it's a public health threat or along those lines. We do know as other tumors are actually going down, the incidence of cancer in the U.S. is going down as we get smarter, diagnose, do more diagnostic tests, more awareness. We see we're seeing more of this. So the lung is in this first part. So the lung neuroendocrine tumors is leading the pack. It's not a tobacco problem. It may be the fact that we are screening more, we're doing more diagnostic tests. The stomach, small intestines, and the cecum is running a little bit lower. Rectal is a little bit higher because we do more colonoscopy, sigmoidoscopies. But it is across primaries. It's not just one primary that we're seeing an increase in incidence. So in the U.S., historically, when we look at the small bowel, we look at about 2.5 per 100,000 cases, and most of these are going to be the terminal portion of the small bowel. We call them ileal primaries, and then about a third of them are going to be at the very distal part of the large bowel or the rectum. There's really not a gender per se with the intestinal neuroendocrine tumors. All those carcinoids of the stomach, colon, and the appendix are a little bit more common in females. African Americans have a slightly more increased. Patients remain asymptomatic usually for years, and it's not uncommon for this to be diagnosed at the time of a pelvic surgery in the females or cholecystectomy or laparotomy. It's not so incidentally, and sometimes the incidental part is when someone shows up and they scan for gallbladder or something, they find out that there are hypodensities in the liver, and not the time of surgery, and at the time of just the procedures, just screening procedures, are totally asymptomatic. When we look at the ones that start within the lung, the incidence here is 1.35 per million. And then when we think about lung, this is really where Dr. Shahan really got engaged, because we're talking about neuroendocrine neoplasms now, not just the tumor. So the tumors are going to be the first ones here, the typical carcinoma, but the next two are the ones that Mary Ann's saying, hey, we're getting more calls about this. We need to educate people about it. It's a totally different biology, and this is tobacco-driven. So we look at the lung and know most of these tumors will be in what we call the bronchus, the lobar bronchus, about 3/4 of them. So when we see a scan like this, we may see a little polyp or a mass that's sometimes flapping in the airway, kind of ball valve effect sometimes. The lung tumors are slightly more common in Caucasians and in females. About a little more than half are symptomatic when they come in. Meaning, so we have a 40% group that are diagnosed incidentally. So we've talked a little bit about the classification from an embryologic standpoint, the foregut, midgut, hindgut. But we also can talk about them as it relates to hormones, functional, non-functional. And you can also classify them based on grade. And this really, the primary kind of sets, but the bottom line, the pathologist is the first person that when they look at it, that tells us what's going to happen individually. So now we're drilling down. So we may have symptoms, we may have some kind of abnormality that's been biopsied. Now the pathology gets it, and the pathologist comes back and says, hey, we can't tell. Maybe it's malignant, maybe it's not malignant. So that's why they call these neuroendocrine tumors. Neuroendocrine neoplasms are tumors and carcinomas. So tumors, not all tumors are malignant. That's a key factor if you can remember that. Not all tumors are malignant. So pathologists sometimes cannot tell. Now that really frustrates everybody, right? Well, what do you mean? They're the ones that playing God here almost. It's not the surgeons are playing God, really. They're really, but the pathologist is the one that's kind of God's assistant, right? So the pathologist is saying to God in the OR, hey, you're cured or you're not cured. High risk for recurrence, or starts understanding what the individual factors are. So we think of grades 1 for neuroendocrine tumors, grade 2 and grade 3. It's just like the gears on your car. Low gear, you're going to go slower. So you get into that second gear, a little bit faster, and you get in that third gear. Fortunately, the third gear for the neuroendocrine tumor, well differentiated, is not that common, fortunately. And it took many years for it to even be recognized that it even existed. That's probably within the last 5 to 10 years that we've recognized that within well differentiated that there is this grade 3. So the historical part was that, if it's grade 3, it's undifferentiated. So they still call undifferentiated in some classifications grade 3. Well, it's a little bit confusing. So you always have to understand that differentiation part. We won't go too much into these other ones, but there's mixed or minate tumors that are variable with adenocarcinoma, the kinds of tumors with them. So when we think about symptoms, we can classify them as saying, is this a symptom of just the tumor, the tumor just creating a pain, for instance, weight loss, anorexia, or is it the tumor that's actually secreting something? And this is a smaller number, something less than 25%. And this is well described because the tumor, because we call it endocrine, is over-secreting, overproducing something vasoactive mediators. And what I mean by that is that these tumors, I'm going to specifically talk about the carcinomas in this case, can secrete what are called neuropeptides or tachykinins. We don't commonly talk about this in medicine because they're more in the neuroendocrine realm in terms of when they're pathologic, so people don't screen with those necessarily. But it's up to the practitioner to kind of tie all the things together. What is, what's not functional? How do you match all this up? And it can be complicated. When you get somebody that's got blood sugar that's elevated, is that from a glucagonoma? Is it a pancreatic primary? Or is that just diabetes? That's sort of an aging factor or such. So when we start thinking about symptoms, we can classify those symptoms based on where that primary tumor is. So there's GI carcinoid, maybe some pain, more GI symptoms, and bloating, and maybe cramping and episodic diarrhea. And this is when it's episodic like that. Hey, you got irritable bowel syndrome. Oh, it can't be too bad, right? Because irritable bowel syndrome is a lot more common than carcinoid syndrome. So that's part of the misclassification because these symptoms are not specific. Lung carcinoids, cough, hemoptysis, pneumonia, infection, dyspnea, chest pain. That could be pulmonary embolism, something. It could be just community-acquired infection. So when we come in, someone comes in with those symptoms, a nodule or that has to be evaluated. Pancreatic primaries, abdominal pain, jaundice, weight loss, abdominal mass. And then we look at some of the functional aspects tied specifically to a hormone that that tumor may be secreting. So think about intestinal primaries and the serotonin, the tachykinins, or the neuropeptides. We really are thinking about symptoms that are going to be anywhere from just secretory diarrhea, and what I mean by that is it's watery. Secretory diarrhea, like cholera, it's the kind of diarrhea that kills. It will deplete you of energy, it will deplete you of minerals and vitamins, and it's really deadly. So from a perspective, in my particular career, I always recall as I joined the training program at Vanderbilt, we had a watery diarrhea patient that could not even be discharged. Secretory diarrhea was, like cholera. So I was charged. Oh, I've heard about a drug somewhere that you need to get for this patient. Here I am, like first-year oncology fellow, and he's telling me to go get the drug. Did I know? I start making calls, and Larry Cole at Mayo was one of the people I called. Lo and behold, this drug really exists. Attending couldn't even tell me the name of the drug. I just heard about this drug that can suppress the hormone mediators. We knew what was going on with the patient. We just didn't have anything to do with it. We couldn't do anything about it. Hospital dependent. That's what it used to be. We had patients that every day for IV fluids, and on the weekends come into the ER. That went on for years. I mean, it's amazing what we had to deal with. And then there can be flushing. Some people never have the diarrhea. Some people have diarrhea without the flushing. But it's not uncommon. Maybe 2 out of 3 times we'll have some of both. Some flushing, some not some. The symptom very much dependent upon what peptides, what neuropeptides are being secreted by the tumor, and the amount of tumor that's obviously secreting. So is extremely confusing is as female ages, I'm going to pick on the female gender because it's a natural physiologic process of menopause. And this disease with neuroendocrine tumors, the median age is right in the early 60s. So theoretically, in the female, menopause is over by the time the median age. But again, you look at the whole spectrum, you're going to have females right around 50 that are going to come in, some potentially with a carcinoid. There's going to be the incidence starts, but and so if flushing develops, oh no, you don't worry about it. Oh, yep, you're going through the change. Normal. Well, let's back up a little bit. What's menopausal flushing? Well, it's more diaphoresis, whole body. It's reversible or suppressible with estrogen. Carcinoid flush, it's almost opposite to dry flush, upper body. Estrogen's not going to touch. Who's going to do those testing on the early phases? Well, probably not your primary care doc because it's a rare, unusual situation. So that's confusing to people. So the flushing part is dry, and it's usually more, it can come on sudden. It's purple, can be more purplish in cases. The diarrhea that comes on eventually chronic, and then watery, and then nocturnal. And that nocturnal is part of that history that needs to come out to see the severity of it. And then usually we want people to exhaust the easy things. So Modium you get at the counter, over the counter, the Kaopectate, whatever, the Pepto-Bismol may help. If we want people to try those drugs first, and now if it's not working, hey, we've got a more serious situation. They come in with everything. So now it's maybe finding the needle in the haystack. You could put any of these symptoms together and come up with a neuroendocrine tumor. It's kind of a bit scary. Anxiety attacks. Well, we could mix anxiety attacks with intermittent abdominal pain. And right there you have it. Well, let's go around and say we've got somebody that might have irritable bowel syndrome and flushing. Whoa, wait just a minute. Could you have irritable bowel syndrome? And that it may not be carcinoid flushing. It may not be the secretory diarrhea, but you got the flushing. You can see how confusing it is to people who don't understand it and see it on a common basis, dissect out all the potential differential diagnosis. Okay, so here, put characteristic of what we think of as neuroendocrine tumors on this side over here, indolent. There's a defect in this fact that the guest in the house won't leave. Okay, with the apoptotic mechanism, these are cells form, and they don't die. They just keep living on. And over time, they accumulate. You get too many guests in your house, and they start stinking, right? So that's the whole process. They don't leave. How do you get rid of them? So that's where we come in. We help you get rid of things that are not supposed to be in your body. They're both benign and malignant. The size is not important in predicting the metastatic disease. These tumors can be very small that have a lot of metastatic disease. 2 to 5 interval time frame of a misdiagnosis. There's delay in diagnosis usually. And then people may die of other problems. And I don't know if that's a good thing or not, but in our area, we want to stabilize this, turn the clock back. And the symptoms may be due to hormonal excess, and we don't commonly see these kind of things on the side where we've got carcinoma. That's what this up here is, carcinoma. Carcinoma aggressive. Breast cancer, colon cancer, lung cancer, You don't have time here as much. You've got to, the defect here is in mitoses. This is where the cells have just gone wild. They have lost the internal controls of stopping division. And so you can kind of tell what happened here. They're going to outgrow their blood supply. That's what's going to limit them in terms of they can't grow unless they get nutrients. And they're always malignant. The size is important in predicting metastatic spread. We look at the tumor and the T in our classification that we use, the T size, the neural presence, metastatic is the TNM classification for cancer. This is where they're all malignant, and we know what the size is. And then they're usually diagnosed within a year of symptoms. Then we talk about screening for these aggressive tumors, mammography, colonoscopy, and now we're getting into low-dose CT scanning for lung cancer, and obviously cervical cancer is really transformed. Screening has transformed that. So here, if we don't get the right here, then this carcinoma is going to, that's more lethal if it doesn't pick up. And here, these symptoms of pain, weight loss, and malaise or may be due to what the tumor makes in terms of cytokines. So one of the things about neuroendocrine tumors is look for one commonality, and that's the expression of the somatostatin receptor. So this is a protein that's going to sit on the surface of the cell. So this is going to be normal physiology in our body, and then in tumors it's going to be accentuated. It's going to be these cells there now are going to be accumulating in this case the marker. This is the Arctria scan, and this is actually the same patient with dotatate. They've been given a tracer peptide, and now the tumor is going to accumulate this because those somatostatin receptors are in higher density in those regions. So these are lymph nodes in the chest, and here we see kidney, spleen, and bladder over here, and then we can see these abnormalities in the liver, and we see these areas here. This is probably the primary tumor, and these other ones are probably the metastatic sites. So never miss a, yeah.
What about the new pattern?
So, yeah, so we now have two ways of doing a dotatate scan, and I'm going to say dotatate because it's the same peptide. So the original was gallium-68, and now in the last several years we've flipped that to copper. Copper is a lot more user-friendly for us. So copper is the isotope we prefer, and we don't lose anything in terms of scanning capabilities. If anything, we may gain a little bit more. We certainly don't lose. But also, people can be a few minutes late to their appointment and still get scanned. On gallium, if you don't show up early, if you're not there on time, you have to be rescheduled. Gallium requires a generator, which means you can only have so many doses per day. So gallium really slows our operations down. So we just can't. With the copper, we could do 50 scans a day. You just order the doses in. So the gallium for us acts as a backup. Curium makes the copper product. I've worked with them for a number of years going to the launch, and they could never see that they were underprepared. So they're having to get more cyclotrons, get capacity built out. They can't right now satisfy the demand. So that's thank God we got gallium as a backup. Yeah. That's a great question. Individualized. You cannot come out and say any scan needs to be done for on a rigid basis. So we give ranges. So if you look at the package insert for dotatate, I'm going to have to get off this topic really quick. But you look at if you look at the package insert one time, you get it one time. That's what this package insert says. And why does it say that? Well, because you're being assessed for therapy. Either you have the expression of the peptide receptor or you don't. So that's really what the scan was approved for. It's not approved as a marker for response. So somatostatin becomes the backbone of what we do. But, you know, there's times that we don't use it. We look at what's best for the patient, and if they're not having the syndrome, there's not very much disease there. It's a grade 1 disease. You know, we may decide to just watch. And when I first started getting into this business and traveled to a number of places and start talking about the neuroendocrine tumors, you don't know how many times I'd have somebody tell me, you know, I've got these patients in my practice and I follow them and they haven't progressed in 10 years. So I'd be talking to them about how you use a somatostatin analog. Well, these tumors don't progress predictably for everybody. Well, you know, that's absolutely right. There are some biologies that are so indolent that if we give them somatostatin, we don't know if we're doing anything. So we call that tumor growth rate. So if you've got potentially no symptoms, no carcinoma syndrome symptoms, and you've got a fairly low amount of disease, and the disease isn't doing anything, we don't necessarily give you somatostatin. You know, it's individualized. But if there is progression, and we feel like it's enough progression, that might be one of the first things we do to control the disease, rather than other things. So we think of drugs. I'm going to kind of move more now to management. I could probably behind on time, but we'll deal with it. Sorry this doesn't come through real well. But this is where the somatostatin drug will work is that it will sustain, and also our mTOR inhibitors, it will just slow down the signaling between cells that are telling cells to divide. So that's one of the calming effects. So these tumors are really smart. They're secreting growth factors that the cell next to it says, hey, I like that. You know, I'm going to grow. So they feed off each other. So the somatostatin comes in there and shuts down some of those growth factors. When we look at inducing angiogenesis, we want to block the blood vessels. We talked about these tumors can't grow unless they get blood. Well, we can block that blood supply with these drugs that are called tyrosine kinase inhibitors or VEGF inhibitors, sunitinib and then bevacizumab, interferon, and the mTOR inhibitors, you know, everolimus. These drugs will slow down or block angiogenesis, and then if we can block that apoptotic mechanism, these cells need encouragement to go away, and our mTOR inhibitors can help those cells, remind those cells not to keep living onward. So we think about our disease and our treatment sort of simultaneously. So if we're looking at the somatostatin receptor, we're looking at these tumors that are well differentiated. If we start looking at glucose, the more aggressive tumors are going to metabolize glucose, blood sugar. And so we'll probably get that question today, so I'll go ahead and ask it. Does sugar feed the cancer? Let's just go ahead and answer. Who had that question? Okay. Well, you know, your brain and your heart has to have sugar to live. So guess what? You're not going to be able to avoid sugar. If you don't, you know, your body's going to make sugar. So when we do these scans, the FDG, we see brain, we see hearts, because that's what the brain and the heart does. And if you have an aggressive tumor, we're going to see that. When we do these scans, we don't see the brain and the heart because we're not crossing the blood-brain barrier to see the brain. And the heart doesn't express somatostatin receptors. So here we could say there could be a hybrid. In some of these tumors, there could be some expression of somatostatin. There also could be some metabolism of glucose. And that tells us a little bit about the heterogeneity, and that's that first word I want you to remember. So the heterogeneity can be seen in the scanning and tell us about biology. When we start looking at these indolent diseases, we talk about hormonal therapy. When we get into these more aggressive tumors, then it's when we start getting what chemotherapy is all about. So when we start suppressing the release of these tumors, how much time? 2 minutes, okay. I'm almost done. We see the reduction of serotonin products. And when Larry Coles was one of the first people to do a New England Journal paper of about 24 people, he saw that within his carcinoid patients that thirds of them had a 75% reduction in their 5-HIA. That was transformational back in the mid-70s. I'm sorry. And then we come along and saying, well, you know, our somatostatin analogs don't get it down low enough, particularly if we want to think about carcinoid heart disease, so we come along with an inhibitor. So telostat came along about 5 years ago. It was transformational as it relates to now we have it blocked. We can block not just the secretion of serotonin, but the making of serotonin. We're going to block the initiation. So these drugs are given together. So we block the formation, block the release, and we have less serotonin exposure. We do know that octreotide in several studies does delay progression. 6% of the time we see shrinkage. We don't pretend that that's going to happen. We know from other studies using with lanreotide and octreotide, we know that these drugs are going to delay progression. Famous studies, the PROMIT trial for prospective midgut carcinoid tumor trial, and then the clarinet trial for lanreotide. This is the red line up here with lanreotide has a better, when we draw these lines out, we always look at the percent, so you can see that the gap there is this was one of the definitive studies that really told us that somatostatin analogs delay progression. Then as we move into these other drugs, the tyrosine kinase inhibitors are shown here. You can see the difference here. Take if you line the difference from here to here, and we see that about a year, we can control the disease for about a year with the tyrosine kinase drugs, sunitinib, and there's a new one that's going to be coming out in a couple of weeks that we'll have for us. And then the mTOR inhibitors, or everolimus, you come over here, 50%, see the difference? Again, it's almost a year of tumor control. Don't usually see shrinkage, but then for chemotherapy, we have capecitabine, temozolomide in pancreatic tumors, and this is the original work that Strasberg did that showed that the overall survival from the onset of treatment was pure. You look at the median, comes around 18 months. Okay, so what our job is to navigate the maze. NTM, navigate the maze. That's where none of us, except the surgeons, can cure. So if we don't cure, it's the Hippocratic Oath. Do no harm. Only problem is the tumor doesn't know the Hippocratic Oath. Right? It's going to cause harm. Our job is to navigate the maze. It is complex. Get even more complex. This gets into our PRT, but the key features today is the fact that we are dealing with an enemy that's wily, like a fox, like it's cunning, unpredictable, and at every turn of that maze, we have to have our antennas up, and we have to think about, hey, we thought we knew this disease 6 months ago. Hey, we're seeing something a little different now. What's changed? What's different? We always have to be skeptical. Because we think we know what's going on doesn't mean we know in the future every time something happens. Stop right there.